First up is Dr. Linda Birnbaum, and she is the former director of the National Institute of Environmental Health Sciences, of the National Institutes of Health, and the National Toxicology Program. After her retirement, she was granted scientist emeritus status and still maintains a laboratory. As a board certified toxicologist, Dr. Birnbaum served as a federal scientist for 40 years. Prior to her appointment as NIHS and NTP director in 2009, she spent 19 years at US EPA, where she directed the largest division focusing on environmental health research. A native of New Jersey, Dr. Birnbaum received her MS and PhD in microbiology from the University of Illinois at Urbana-Champaign. And now, Linda, I welcome you to kind of start off with initial thoughts on the presentation, and but leaving time for other panelists to get going.
So I would say that there's what we've heard from both Jamie and David is that there are a plethora of effects due to PFAS. This is not a chemical that affects one sex of one species with one kind of endpoint. We see effects in multiple tissues at multiple developmental stages that we need to think about. I'm a toxicologist. When I talk epi, I think I get myself in trouble. But I think, as Jamie pointed out, there are many similarities in some of the effects that have been observed in people, and I would say they're supported by the animal data. There aren't too many examples that I can think of where there isn't a parallelism that can occur. I actually started working on PFAS in the late 1980s and dropped them when I showed that they were not dioxin-like chemicals, and I was focusing at the point on dioxins. So I think it's important to realize that while the liver effects in animals are often attributed to PPAR alpha, as Jamie mentioned, for example, liver tumors do occur in mice that are knocked out, where that receptor is knocked out. Jamie brought up the point, which is very important, that we have multiple mechanisms of action here. There are multiple receptors. There are, the PPAR, it's not just PPAR alpha, it's also PPAR gamma, which is associated with some of the effects that are seen either related to fat or bones, for example. There's the inhibition of fatty acid transport, their interference with mitochondrial function, as she mentioned. And I think that it's important to realize that not all of these occur at every stage in every tissue all the time. Another point I think is worth mentioning is we hear about the short chain and the long chain PFAS. These are really terrible descriptions of the molecules. The long chains in general have longer half-lives, but I would tell you that some of the compounds which are considered short chain can have half-lives of 2 months, 4 months, 6 months, 8 months. That is really hardly a short chain or a short half-life kind of compound. I really think that keys that we should be focusing on, yes, many of the effects that have been documented in the C8 study, which were largely focused on adults, although they did report hypertension during pregnancy, for example, are the developmental effects, which, unlike the liver, are not reversible when you remove the compounds. I think it's important to realize that again, we've talked about PFOA, PFOS. Jamie mentioned PFDA and PFHXS and GenX, for example. And I should say that the data that exists, which is very limited for a number of the, quote, short chains, whether that's GenX or some of the fluorotelomere alcohols, which are metabolized to carboxylic acids or sulfonic acids, for example, they are showing the same effects that you see with a related compound. Now, maybe I should say they are showing at least similar effects. So while all the effects may not be identical, I think there's a great deal of similarity that we are seeing in the limited data. And as Jamie mentioned, for example, with GenX, the liver concentration associated with liver problems from GenX, if you focus on the concentration in the tissue, and that's a point that I think is worth making, that although the whole body half-life may be much, for example, shorter for, say, GenX versus PFOA or PFOS, when you actually measure the tissue concentrations associated with an effect, They are in fact similar, or Gen X may be even more toxic than PFOA. And the same thing is true for some other endpoints with PFOS.
Hey, Linda.
And Gen X. Just about done.
Okay.
Okay. Yeah, I could go on. I think it's important that there are some key research questions that we really have, that should be thought about. And some of that is the issue of mixtures that has been brought up before. I think another thing that came up yesterday loud and clear is that there is so much more PFAS out there that we are not measuring at all. And the point is that that's really something that we have to be looking at. We have to think, when we move from one PFAS to another, are we just again whacking a mole, or are we on the chemical conveyor belt? And I think we do need to consider a class approach to PFAS. When you have over 9,000 chemicals that are PFAS, there's no way that we can ever test all of them, either in toxicology studies or look at them environmentally. Thank you.
All right, thanks, Linda. And there'll be time for more discussion later. I just want to be sure we get through everybody on the panel. Our next speaker is Joseph Brown from Brown University. Dr. Brown is an associate professor in the Department of Epidemiology at the Brown University School of Public Health. He was formerly a school nurse in Milwaukee, Wisconsin, before receiving his master's and doctoral degrees in epidemiology from the University of North Carolina, Chapel Hill. He completed postdoctoral training in environmental health at the Harvard School of Public Health. And I'll turn it over to you, Joe.
Thank you. And I want to thank the organizers for inviting me here to be part of this discussion. So this was really great talks by both Jamie and David. And I think one of the things that really I came away with it, that, I've always been sort of perplexed by this lack of consistency between the association between PFAS and cholesterol in the animal and human studies. And I think Jamie's comment about the fact that there is an effect, and while it's in the opposite direction across species, that by itself is compelling. It means we have to try to explain why that is. And, I'm reminded of studies of other chemicals like BPA, where there's profound differences in the way those chemicals are metabolized across species in rodents versus humans. And thinking about some of these differences, some of the reasons why there might be differences in these effects is important, whether it has to do with metabolism or actually mechanism of action. I want to talk a little bit about what I think are some of the research needs, and build on a few of the things Linda was saying. I think this need for more on looking at sources is really important, especially given what this panel's charge is with reporting results back. People are going to want to know, what do you do? You tell me I've got a PFOA of whatever, what do people do with that? And that's, we need to be able to both give messages about ways to prevent exposure, because these chemicals are persistent. We're not going to reduce exposure simply by telling people avoid drinking water. That's not going to reduce their body burden, but we need to have some way to do that. And there's a lack of that right now. And it may not be possible, but I think it's worth thinking about some of these, if there are ways to potentially reduce exposure and in terms of body burden. And absent that, if we're concerned enough about health effects, do we need to engage in preventative medical screening, or even thinking about other tertiary prevention techniques to ameliorate the effects of exposure? I think the mixture issue is still one that we're just starting to scratch the surface with PFAS. And there's a variety of methods that have been developed in the last 10 years to study the effects of mixtures, and with more and more sophisticated biostatistical techniques available, and some that are actually being developed really with policy questions in mind, and thinking about what would be the health effect if we reduce exposure to 5 of these PFAS by 25%, or one of them by 100%, and another by something else. And so I think there's a lot of ways that we can start addressing this question, and using the data we have at hand to empirically evaluate what the mixture effects are, and determine what's the total effect of that mixture, and then what are the components that we're really worried about. And I think it's important within that to acknowledge that we could see different mixture effects in different populations, simply based on the fact that one population may have very high exposure to one or more of these compounds compared to another one. So it is possible that there may be different mixture effects just based on exposure profiles. So understanding the nature of these exposure profiles in different populations is going to be important, and not being dismissive of a lack of consistency in mixture effects just because they're not similar effects across populations, and acknowledging that they may actually be due to the differences in exposure profiles. And I'll stop there.
All right, thanks a lot, Joe. And our last panelist is Dr. Matthew Longnecker from Ramble Consulting Firm. Before joining Ramble in 2015, he was a tenured senior investigator in the epidemiology branch of the National Institute of Environmental Sciences. He has an MD from the Dartmouth Medical School, SCD in epidemiology from the Harvard School of Public Health, and is board certified in internal medicine. He has published over 225 scientific papers in peer-reviewed medical and scientific journals, and has an ongoing interest in contributing to and evaluating epidemiologic data that inform risk assessment. Dr. Longnecker's current research, although funded by industry, is conducted without sponsors' interference. His research focuses on quantifying bias in epidemiologic results due to unmeasured, confounding, or reverse causality, and on systematic reviews of potential health effects of per and polyfluoroalkyl alkyl substances. All right, welcome, Matt.
Thank you, Jane. So I was going to focus on the talk that David Savitz gave about the epidemiology. And I just wanted to respond that I thought the review was comprehensive and balanced and very practical. And one of the things that I liked about it in particular was that he had the outcomes grouped into these tiers. And so, for example, the first tier, he called the outcomes that were most clearly affected. And I mean, now I would take issue with him. Maybe they're most clearly associated, but nonetheless, I think what he has there in that top tier has a strong justification. And so the NIS, the guidance panel, they're probably going to be looking to authoritative sources of information about what are the outcomes that are of greatest potential interest here. And so I thought it might be useful to contrast what David Savitz just showed us with what the ATSDR has in their recent review that came out in May. And so they had in their document, page 6, what they called results suggestive of association without established causal relation. And so they had 6 items on their list, and 4 of those items were on David Savitz's list. So there's a high level of agreement there. And the items that the ATSDR had that David Savitz did not have were pregnancy-induced hypertension and preeclampsia, and a small decrease in birth weight with PFOA or PFOS. So with respect to the pregnancy-induced hypertension, it might be interesting to hear from Dr. Savitz why he doesn't have that in his most clearly related list. And then with respect to the birth weights, you know, the ATSDR document came out fairly recently. So there was a meta-analysis on PFOS and birth weight that just showed up in PubMed early this year, probably too soon for ATSDR to see it. But maybe Dr. Savitz has seen this meta-analysis about PFOS and birth weight that was by Gerlinga et al., and maybe that influenced his thinking. Anyway, it'd be interesting to hear him comment on that. And I think I'll stop there. Thank you.
All right. Well, thanks, Matt, and thanks everybody. I'm gonna turn it over to the panel for questions, but I want to remind everybody that our charge is to make recommendations for healthcare providers about responding to PFAS exposed populations. So, with that in mind, if you were going to pick one outcome and I think everyone on the panel, if you were going to pick one outcome that we should try and we should make a recommendation about, what would you pick, or would you pick any? And I'll start with Joe because he's my front corner here.
So I think the vaccine response is one of the more compelling ones, in that there's an alignment of both the animal data and the epidemiologic data. I think one of the other members mentioned that there's not the association linked to clinical endpoints yet. I'm not sure if that's essential, given that it's going to be quite difficult to do studies of true vaccine having reduced response to it, or clinic infection with diseases like measles, mumps, and rubella. And cholesterol is the other one, and I think there is some potential for non-causal explanations from that. And actually, Matt was just on a paper that he just published yesterday, or at least I saw the alert for it on PubMed yesterday, that outlined some of the potential non-causal explanations for the association between PFAS and cholesterol. But I think those are the two places where we have a remarkable amount of consistency, across species, and some serious health implications in terms of those disease endpoints.
Thanks. All right, Matt Longnecker, what do you think? Is there any that you would pick?
Well, let me comment on the cholesterol association. One of the observations from the C8 study was that the PFOA exposure, as estimated with a model, was not related to the incidence of cardiovascular disease. So yes, there's an association with cholesterol, but not with cardiovascular disease in the C8 study, which is the most powerful study available to us. But to answer your question, Jane, if I had to choose one, I would say antibody response, and recognize that we don't yet know how that translates to clinically relevant infectious disease.
Cool. All right, David, what do you have to say? What's your thoughts?
It's interesting. Coming back, and I appreciate, Jane, you're steering it back to your mission. If the mission was regulation of environmental levels, and Jamie and I have been involved in that, many of you have, it is a very different standard to say, do we know enough to not want that in our drinking water, to regulate it at lower levels? Very different than saying, how do we change medical care in response to, or health care, let's say broadly, in response to this? I think that I would only say it reinforces currently recommended procedures. If you are concerned about the antibody response, by all means, get a flu vaccine. In the COVID era, wear the mask when you need to wear a mask. Nothing that is different, other than if there is some subtle effect, modest effect. Let's assume there is for the moment, that it translates into a somewhat elevated risk. Well, as Ned noted, there are dozens of factors which affect antibody response. I was amazed when I looked into this. We don't have different guidelines if you have diabetes. It's like, just reinforce it. I would say the same thing with the cholesterol. If you are concerned, reinforce the need to be screened and treated. I don't find directions where it says, oh, now you're in a different category of people, that your approach to healthcare should change in response to your history of elevated levels.
Okay, thanks. Jamie, what are your thoughts? Or do you have, you can
Well,
also.
Yeah, not being an epidemiologist or an MD, this is kind of a challenging question. But I mean, let's look at things from a toxicological perspective. The nice thing about measuring responses to antibodies is that it's a fairly immediate response that can be measured, as opposed to heart disease, which could occur many years after exposure. So you can look at antibody responses immediately after the antibodies have been generated from a vaccine. So it may tell you about something going on right now during a current exposure. I also want to point out that cholesterol, in terms of changes in animals, isn't as easy as just being an opposite response of what is observed in humans. Tom Webster presented yesterday, and he's done quite a bit of work with cholesterol in animal models, and some of the responses might be non-monotonic with some weird ups and downs, and they're still trying to work out the details there. But I think, anything somebody can do to prevent chronic disease from occurring and get a heads up on something so that they can take action now rather than later seems like a good preventive measure.
Thanks. All right, Linda.
Thanks, Jane. I would kind of go along with the things that people have said, with the immune being the first one. And I would suggest that there is growing amounts of data which show that in different human studies, there is an association between exposure and increased risk of infectious disease and hospitalizations. And there is some data on measles sensitivity as well. There's the one paper that suggests that people who had higher PFAS had more severe COVID. Again, we need a lot more work in that area, but I think the perturbation of cholesterol is important to consider. And I think the thing is, I think the thyroid is something. Now, multiple different things can perturb thyroid homeostasis. But as Jamie was saying, it's the perturbation that we might be looking at rather than specifically the up or the down level. And a number of other PFAS has been associated with perturbation of thyroid function, in addition to PFOA and PFOS. And one thing that hasn't even been mentioned, although kidney cancer seems to be, it's still not something you're going to see in a few people, but there is evidence that PFAS alter kidney function in both animals and people. And I think that could be a measure that you could look at the GFR or something like that.
All right. Does the committee have any questions? All right, I have some more then. So I think this issue of toxicologists, where you have things happen one chemical at a time or few chemicals at a time, whereas in epidemiology we study the world and its complexity and mixtures. And so how do we marry this? David in his presentation said we just need to think of PFAS as a class because what we see in one study. And then Jamie commented that certain combinations of A and B may give different responses. How do we, in thinking about how we would even define PFAS exposed people and PFAS health effects, how should we think about those mixtures, not necessarily statistically, but kind of broadly? Do you have thoughts on PFAS individually versus a class and making health recommendations about that?
I think one thing is that, this has been alluded to in some work in a review by Elsie Sunderland, but, thinking about, are there different mixtures or profiles of exposure associated with different exposure scenarios? So it's cosmetic use associated with certain exposures, maybe from from precursors being in cosmetics, and that may be, certain subsets of the population who are higher cosmetic users might have those exposures. Certain drinking water patterns, depending on where you live, associated with that. Fish consumption is another example. So, can we sort of do this? Are there sources that are linked to certain profiles of mixtures or patterns? And that can be informative, in terms of then giving of messages aimed back at people of ways to prevent exposure. It's not going to reduce exposure, though.
So, Joe, just that I'll make the comment that when we've looked at fish consumption, the profile of the compounds that are measured, and that of course has varied from study to study, is often not the same. Depending where your fish are swimming, can alter their PFAS profile. I think the idea that again was brought up yesterday, both by Elsie and Tom and maybe some others, that we are only measuring, even if you're measuring 25 or 29 or 49 specific PFAS, that may only be 20% of the total organic fluoride that is present in your samples. And I think that is a key research need to find out. But I think with mixtures, the fact that in epi studies, we have some similarity between different populations who have had different exposure suggests that those strong responses, taking certainly the 3 that David put up, are related to PFAS in general. As I said before, there's no way we're ever going to test all of them. And I can tell you that there's a proposal right now to create a mixture that resembles the PFAS in the Cape Fear River and test those toxicologically.
Okay, so if someone else has a question, Brian, you want to take it?
Yeah, I was just turning my video on. Sorry about that. So I have a epi question and a toxicology question. So we'll see if we have time for this. But, the epidemiology focused on health effects. And one of the things is we're trying to understand sources of exposure as well in, human contributors. So what does the epi literature tell us about sources of exposure? And perhaps how could it be taken further to give us more information on that? And then I guess my toxicology question, if there's time, we're running out of time, would just be, there's so many chemicals in the class, and what would be the role for structural activity relationships and that kind of mathematical modeling, whether to inform, I guess, current or future, recommendations?
I can speak a little bit to the exposure quickly just because of time. I think we have some ideas of what exposure sources are, but I don't think, and there's some estimates of relative contributions of those sources at various life stages, but I don't think we have a really good handle on that from, beyond some extrapolations that have been made in some risk assessments. And I know there's a call for proposals out right now to really, from the EPA, to do a more thorough characterization of the relative contribution of different sources. But I do think that is a research gap right now, particularly for emerging PFAS. But I think it's important to acknowledge that this can vary both, with age, time, and place. So we have to, acknowledge that it's not going to be the same for everyone.
Maybe if I could just, I'm sorry, just briefly, go ahead, sorry.
Yeah, thanks. Just with respect to the question that Brian Lind just posed about structure activity relationships and the different PFAS compounds, you would have to know the mode of action. You would have to know the mechanism of the toxicity, and we don't really know that.
Well, Matt, I can tell you, you don't have to know the mode or the mechanism to necessarily. EPA is currently looking at binning about 100, well, over 100 different PFAS. They are basing it upon read across, mainly using what's known from in vivo data, but also using a lot of the in vitro data and the in silico data. They are basing it in part upon the OECD binning that has occurred and in part upon some of the recommendations that the industry has made as well. Whether that ends up, how much further that goes, I don't think any of us knows, but there are different criteria you can use. And I think you don't have to know everything in order to start binning.
So Ned said we can go to 2:40, so we have a little more time. David, did you want to respond?
Yeah, very quickly on the question of Brian asked, it's a good question about the sources. We know that contaminated drinking water has a dramatic effect on the variation in blood levels. That's absolutely clear. The part that to me remains less clear is once you get that out of the equation and it's back to the levels we all have in our normal drinking water and in our food and in our food wrapping and so on. The only thing that, I don't know if there's been work done on this, but one of the when they stopped the manufacture of PFOA and PFOS, there has been I don't know what the percent decline is, 80% decline in blood levels or something very pronounced. And I don't know if there's been sort of tracking through, why did that happen? Where did it go when they stopped making it at the factory? Why is it not in people's bodies? And what is the pathway? I think it could be very informative. It just is a thought I've had. And again, maybe there's literature out there, but it could tell us a lot, I think, about why it went down so much.
Thanks. All right, Erin, you have a question?
Yes, thank you. I want to thank the panelists and presenters. It's the fabulous presentations today, and then also this dialogue has been excellent and very helpful. And we really value your work. So my question, I want to go back a little bit to this. It's kind of nagging on me. Our work right now sits in between recommendations for the community who are, as you know, clearly concerned. They come mainly to their primary care physician, asking them questions. And we're hearing from, we've heard, testimony, insight from physicians, mainly with the PACEs, saying in many cases, they have reservations about providing testing or information that is not clinically relevant. Understood, they're not trained in PFAS in school, etc. But I'd love to hear this group's comments on, because we've hit on it, but not dove deep, when your reflections on animal studies, human studies, but yet it may not reach the point of clinical significance. So what would be your recommendation for the communication to physicians in that case? Anyone can start. Linda.
Thanks, Erin. I think I would be saying we need to work on reducing exposure. We need a better understanding of where these chemicals are. There is some data that says people who eat more fast food have higher levels of PFAS. That may relate to the packaging information. We now know that there's PFAS in, personal care products. We know that there's PFAS that has been used on carpeting and rugs and your hiking boots and so on. So I think we need to be pushing to reduce exposure. On the other hand, it's really not fair to make it an individual choice as opposed to a policy action.
Maybe I could comment briefly. Again, I agree. If it should be actionable in some way. I think there's a danger almost in saying, here's your blood levels, thank you, goodbye, and not either having some message. And I think Linda gave it is, although it's, you don't want to overstate it, there are things that you can do that would be reasonable approaches to reducing your levels. And I think that you need to be clear, though, the part I worry about, I do some work with the state of Michigan on this, and it's really a challenge, is not to make people feel that they're somehow doomed. They've measured elevated PFAS levels, and there's, their fate is, sealed now. I think it should either be actionable on the clinical front or on the exposure reduction front, not just here's the facts and leaving it at that.
Anybody else?
Yeah, I'd just like to add that, I work with several firefighters and firefighter groups, and they get annual PFAS blood levels. They usually get what they call the PFAS 6. And then they want to know, what do I do with this? And like David just said, they get afraid of their elevated levels, but then nobody directs them as to what they can do to reduce their exposure. And in their workplace, they don't have many choices. But what should they do to understand if they have risk factors? So that requires them to know a little bit about their own health history, and then working with a doctor who might go, you have a family history of high cholesterol, your PFAS levels are elevated. Let's look at your cholesterol and then evaluate it over time and see if we need to do anything about it. That would be an approach that I think would make me feel good if I had elevated levels in that history.
I want to make one comment based on what David said, which is we have seen a decrease in PFOA and PFOS since they stopped being intentionally produced. And that's because they are still being produced as breakdown products during the life cycle of some of the products. But I think the point is that's something you can also tell people to lessen to let them know that there is something you can do. If you stop your exposure, your levels will decrease. Maybe not tomorrow, but over time.
I'm going to leave it just at this one question. So Jamie pointed out, like, we could tell people if they have elevated levels. I don't know what that is. So elevated level in 1999 or 2019. So even as a charge of like who is highly exposed, I think it's something we don't answer well. And I don't know. I don't know if there's any thoughts on that.
Well,
but
just again, very briefly, I think Scott Bartell may have set this up. You want to know it may not answer people's direct question, but you can sort of find out your percentile ranking in the NHANES data. And so it may make people worry if they're at the 90th percentile, make them feel good if they're at the 20th percentile. But that right now is the only normative data we have to say, are you in an unusual group or are you pretty typical?
All right. 29 seconds till break. Any urging issues? All right. Well, thanks to our speakers and our panelists for a really enlightening discussion.